I'm Dr. Sudheer Nadimpalli. I'm a consultant pulmonologist at Virinchi Hospital and I've been practicing for the past 4 months in this hospital. We have a team of pulmonologists and critical care specialists working with us, and my colleague Dr. Uttara Vijaykumar is also a pulmonologist in this hospital. So we care for all the respiratory problems which commonly occur in patients, ranging from airway diseases, sleep problems, TB, other infections like pneumonias, lung cancers, and we also do various procedures like bronchoscopies, thoracoscopies, and we have a full set of a pulmonary function testing lab, including spirometry and a sleep lab. We're also well equipped with the whole range of bronchoscopes, like the regular adult bronchoscope, the ultra slim video bronchoscope, which is predominantly used for children, and we also have a range of rigid bronchoscopes where we can utilize for things like foreign body removals and to do any tumor debulking. For today, I'll be discussing about airway diseases, which consists of usually asthma and COPD, which are the two main airway diseases that we come across in our day-to-day practice. Asthma, as you all know, is a genetically predisposed condition where you have one member of the family who has had asthma or allergies, and the patient usually is susceptible to asthma thereafter. And asthma is a disease which is very much controllable and usually has symptoms such as cough, breathing problems, wheezing, and very thick sputum, which bothers the patient throughout the night, and then they have sleepless nights with it. And we usually diagnose asthma with a clinical examination followed by X-rays and pulmonary function tests like spirometry, which is like a normal regular breathing test. X-rays are done in asthma to rule out other diseases and not to diagnose asthma. Asthma can sometimes be misdiagnosed in most of the patients, or probably given a different name to it, which comforts the patients more than anything. Some of the very common causes of asthma is the pollution, which has become a very big factor, which has increased the asthma incidence from about 5 to 7% about 10 to 15 years ago to almost 20% in the population at the present time. And we all know that the vehicular the pollutants like sulfur dioxide is one of the incriminating factor, and that is the reason we need to do a bit more from the preventive aspect in trying to control the pollution to try and decrease the incidence of asthma in these particular patients. Whenever we have patients with asthma, we usually assess them in the clinic. Regular follow-up is one of the very important factors that determines control of asthma, and a proper reassessment will only help the patient in reducing the symptoms and improving his quality of life or her quality of life. When we see children with asthma, predominantly they have the lost school days because of lack of night sleep, and then they are very tired, and then the performance at school goes down because of the exacerbations of or the flare-ups of asthma. So we normally insist on the parents bringing the children back for regular follow-ups and using regular medications which are prescribed by the doctors. When it comes to the treatment part of asthma, we normally prescribe very effective locally acting inhalers uh, which have to be taken in a proper way, and because the technique of the inhalation is very important for a proper drug delivery. We also give some of the medications like oral steroids. When it comes to acceptance of predominant of the patients regarding when we say they utter the word oral steroids, uh, people get panicky because steroids in general are not very safe, but it is only on the long term that you have steroid side effects. Normally, when we prescribe steroids for flare-ups of asthma, we only do that for about 5 to 7 days, which does not harm the body in any way. So the social stigma about steroids, I think, needs to be addressed every time the patient or the family member assists, so that they do not have that bad opinion about a short course of steroids. We also have a lot of stigma related to inhalational drugs. People are of the opinion that the inhalation medications are addicting, which is not true. It's important that we teach the patient the inhaler technique whenever the patient goes out of the hospital, before the patient goes out of the hospital, and ensure that they're taking it in the proper way. Whenever we come across children and the very elderly, we try to give nebulized management for these particular patients because the inhalation techniques are very poor with this set of populations. Some of the people are not well educated, and they come from a low social backgrounds where and where stigma is a problem. We have no other option but to use oral medications, which are not very safe most of the times. So whenever we treat patients with asthma, we also have the responsibility to tell them about preventive methods, like trying to avoid the triggers which can bring on the asthma, like exposure to heavy dust, some of the very strong perfumes, strong smells in the form of either a bleach or an agarbatti smell, and strong perfumes and things like that. So we also advise people to try and see if they can avoid pets if they have any, and so that they do not go and fondle them very often when they have flare-ups especially. So these are some of the preventive measures that we keep telling whenever patients walk into the clinics. And as part of the preventive measures, we also explain about the need for vaccinations in this set of population, because some of the viruses are really bad when it strikes asthmatics, especially the flu virus or the influenza virus, and especially the swine flu. So when it comes to vaccination of asthmatics, any asthmatic of any age should be vaccinated for influenza and also for the pneumococcal vaccine. So the influenza vaccine is given every year and the pneumococcal vaccine is given every 5 years. What if asthma is not treated? So if asthma is not controlled or not, as you say, treated properly with the inhaled medications and the nebulized medications, with a permanent narrowing of these tubes, which is not good. So whenever we come across patients with asthma flare-ups, we tend to treat them aggressively with oral steroids and as well as inhalational medications which go to the airways directly. The other important airway disease is COPD or emphysema, which is very common in smokers, and we come across some of the patients who have never been smoking or even exposed to passive smoking, coming with what looks like a COPD or a chronic obstructive pulmonary disease. These are usually the rural women who have been exposed to a lot of biomass fuel, like burning wood for cooking, and the age-old traditions of the non-LPG cooking, where a lot of these smoke, which is almost equivalent to cigarette smoking, can damage the air tubes or the breathing tubes and cause this condition called COPD or emphysema. So this condition is predominantly seen in smokers, as I have said, and depends on the number of years of smoking as well. Unlike asthma, the COPD or the emphysema is an irreversible disease where predominant part of the lung and the breathing tubes are damaged to a very great extent, and we have to manage them differently from asthma. So these kind of treatments of inhalational medications are usually the first line of treatment, or the first line of management for these kind of patients, along with some oral tablets. And sometimes it may so happen that some of these end stage lung disease who have been so severely damaged can end up in having home oxygen as well. So unlike asthma, there is a necessity for these patients to be counseled about stopping smoking if they are caught early in the clinic. Because this is a progressive disease and can damage irreversibly. So whenever we have a chance in the clinic, we try to counsel on quitting smoking and trying to avoid excessive pollution from the biomass fuels, and try and get to a stable. We try to get them stabilized with inhaled medications and oral tablets, and sometimes if they come in an exacerbation, we might have to give them oral antibiotics, because infections are usually the triggers for COPD flare-ups. And like asthma, the COPD patients are also counseled about taking vaccinations on a regular basis. For example, the flu vaccination every year, and the pneumococcal vaccine, which is the pneumonia vaccine, every 5 years. We also counsel about quitting smoking every time patients come into the clinic and who are current smokers. We also tell them the various options of how to quit smoking, like the medications, sometimes proper counseling through psychiatrists, and counseling the family members how to cope up with the stress. And the various medications that we have are the Nico gum, or which is the nicotine chewing gums, and one of the commonly used medication is called varenicline, or called Champix, which has to be taken for a 12-week period to come off smoking.